I am, yeah. I'll start it as, hello everybody. I'm Greg Bangs with Booz Allen Hamilton, and I'd like to welcome you to this afternoon's panel, Can We Afford Our Health? Now, if you're looking for the Without Water Revolution panel, that's over in Greenwald Pavilion. One housekeeping note reminder as we get started, could you please place your cell phones on vibrate? I appreciate that. Now, let's see if we can afford our health. We'll be led in this discussion by Dr. Kevin Vigilante, a Senior Vice President at Booz Allen Hamilton, where he leads a team of clinicians, researchers, and public health professionals who provide strategic consulting services. Prior to joining Booz Allen, Dr. Vigilante worked on the medical faculty at Yale and then at Brown. At Brown, he was Director of Emergency and Ambulatory Services at the Miriam Hospital and held an appointment in the Department of Immunology and Infectious Diseases. Kevin has been published in academic journals and top-tier media outlets on a wide range of topics, including research innovation and informatics, tax policy and healthcare reform, and care for underserved HIV populations. Ladies and gentlemen, Kevin Vigilante.
Thanks so much, Greg. So, welcome, and thank you so much for coming today. We're going to have a great session. We're going to explore the question, can we afford our health? And as you can see, we have a very distinguished panel here that I'm going to introduce in a minute. But first, I'd just like to briefly tee up the topic. You don't have to be a healthcare expert to understand that healthcare costs are soaring out of control. The national expenditure on health went from about 9% of gross domestic product in 1980 to about 18% of GDP today. We spend far more per capita on healthcare than any other developed country. Yet life expectancy and other measures of health lag far behind other nations. So this imbalance, this gap, this discrepancy between what we spend and the health we aspire to makes the question, can we afford our health, very relevant to the national debate. Today we've assembled a very impressive panel, as I've mentioned, to explore this question. And I'm going to take a moment to introduce each panel member. I really have to apologize in advance for the brevity of my introductions. If I enumerated all their achievements, we'd be here all day and we wouldn't get into the topic. I'm going to start from my far left here. Robert Rubin is co-chairman of the Council on Foreign Relations and chairman of the board of the Local Initiative Support Corporation, the United States' leading community development support organization. He serves on the board of trustees of Mount Sinai Medical Center, is a member of the Harvard Corporation, and has been a member of the board of trustees of Citigroup. In addition to numerous other achievements, Mr. Rubin served as the 70th Secretary of the Treasury during the Clinton administration. Next, in the middle, Peter Orszag. Peter's a PhD economist who is vice chairman of corporate and investment banking and chairman of the Financial Strategy and Solutions Group at Citigroup. Dr. Orszag served as director of the Office of Management and Budget in the Obama administration, and prior to that was the director of the Congressional Budget Office. He also served as a senior economic advisor in the Clinton administration in multiple capacities. To my immediate left, Dr. Kenneth Davis is the president and chief executive officer of the Mount Sinai Medical Center. He also served as dean of the Icahn School of Medicine at Mount Sinai and was chair of Mount Sinai's Department of Psychiatry for 15 years. Dr. Davis was president of the American College of Neuropsychopharmacology and has had a long and distinguished career in neuropsychiatric research for which he has received extensive national recognition. So, thank you, gentlemen, for participating. I'm going to start the conversation by posing a number of questions for the first half hour or so. Then when we're about a half hour into it, I'm going to turn to the audience. So get your questions ready, and then I'm going to come back to the panel, and we'll close up in the last 5 minutes. So this first question's for Peter. Peter, you know, healthcare is an industry, right? And when other industries grow, manufacturing industry, automobile industry, technology industry, we're generally happy about that. When healthcare grows, we're not happy. We worry. Why is that? And is there any way to imagine restructuring the health sector in a way that it would make us happy that it's growing?
Yes. So first, I think the reason that people worry about rising healthcare costs is just how important those costs are in a whole variety of dimensions. To the federal budget, where the long-term fiscal gap is almost entirely driven by the rate at which healthcare costs grow. At the state and local level, where over the past 3 decades, healthcare costs have been crowding out, for example, state government support for higher education. And in terms of workers' take-home pay, because as employer healthcare costs go up, the scope to provide money in the form of take-home pay is constrained. So that's why it all matters and might generate a little bit more anxiety than other sectors. But I think the key issue is not how much we're spending, but how well we're spending it. And I think the reaction to rising healthcare costs would be much different if we felt like we were getting our full money's worth out of every dollar we did spend. My view is the evidence suggests, and the evidence, there are different folks who reach different conclusions, but it's not unreasonable to suspect that somewhere between a quarter and a third of the spending on healthcare that we currently do doesn't actually improve health outcomes. So that is a massive amount of money. I mean, at today's spending levels, that's like roughly 5% of GDP. And so you'll hear throughout this whole Ideas Festival lots of ideas about improving efficiency and raising productivity and how to improve economic growth. There's not I guarantee you, there is not a single idea that you will have heard throughout this entire Ideas Festival that has the potential to raise or free up 5% of GDP. That is a massive $750 billion a year, a massive amount of money. So I think that's why we should be worried. Now the question is, what can we do to try to make the system more efficient? And here I think there's actually some good news. Over the past few years, healthcare cost growth has actually slowed down dramatically. I don't think that's entirely, it's partially, but I don't think it's entirely because of the economic weakness. And it points to the possibility that by changing the way we pay for healthcare, by digitizing it, we can get a better value proposition. Right now, the dominant form of compensation in the healthcare system is fee-for-service. We pay for quantity. And guess what? Incentives matter. When you pay for quantity, that's what you get. So we have a lot of quantity. What we really need to be doing is paying for quality, because only by doing that will you create the right incentive structure to produce that. And we are moving more rapidly than I think many people appreciate in that direction. At the same time, a key aspect, by itself it doesn't do very much, but in conjunction with the change in the payment system, digitization matters. None of those other sectors that you mentioned were able to significantly raise productivity, or let me put it this way. In many of those other sectors, digitization was an absolutely essential part of improving the value proposition. And the same thing is true in healthcare.
So, but if you look at what's driving costs, I mean, it's a couple of the real two big cost drivers are certainly the aging of the population and the technology acceleration, right? And it doesn't appear, I mean, we're going to continue to get older, and technology is going to continue to march forward. And for some reason in healthcare, technology seems to add expense rather than, sort of bring down prices. So Bob, if I just might direct this to you, is there some point, even if we become more efficient, is there some point at which it will be simply too expensive to be as healthy as we aspire to be, or even have the capabilities? I mean, Ken, you brought up an interesting point this morning. Suppose we unlocked the biology of aging, which is possible in the next 20 years, and we could live to 120 years old and have all the technology. Is that something we could afford to do? And
yeah, I think that's the right. I think, was that Ken's comment this morning?
Yeah, it was Ken.
But
it's now 25%.
Yeah, but I suggested the idea. He just followed up with that particular. It was actually my idea.
I tried moderating these guys this morning. It was impossible. So we'll see how it goes this afternoon.
I think you've asked the right question, and I think, look, I've been exposed to this a fair bit, though I'm not a healthcare expert, but it has always seemed to me that ultimately we just simply do not want to face the questions that are embedded in the healthcare system. And you said, how do we decide how much is too much for our society? And in any other field, if it's automobiles or some such thing, you have supply and demand, and that allocates. But we treat healthcare, I think rightly, as something different. It has a certain special value. That's why we have universal coverage. But it also means you can't depend on market forces to decide what percentage of GDP should be allocated to health care. And I think we are ultimately going to have to face a question that we implicitly deal with access. We allocate access. We don't have to provide everybody with full access to everything they want. We do it to all sorts of means, as we know, including affordability, insurance, one thing or another. But I think it's an issue we have to face increasingly as demographics continue to make this a more difficult problem, and as people live to greater and greater ages, because the healthcare issues that go with aging are obviously considerable. So I think the right way to frame it is exactly what you just said, because I think even though it's a hypothetical, I think it drives you to think about how are we going to deal with the questions of access and allocation of healthcare in our society. And those are both practical issues and moral issues, and I don't think we've ever faced it explicitly or openly, and therefore it comes into our system in all kinds of implicit ways instead of being faced explicitly. But if you face it explicitly, you have some very difficult problems too, because then how do you decide how to optimize for whatever cost you're willing to incur? How do you decide what the percentage of GDP you want to spend? And what are the underlying moral issues? What happens to the concept of sanctity of life in that context?
So let me turn around. Let me bring us to you, Ken, because we've talked about technology adding cost, but you're one of the sort of premier researchers in neuropsychiatric research, have developed some of the early stage molecules that have really sort of have made an impact in Alzheimer's and other diseases. Is there a way to think about innovation in the future differently than is there something qualitatively different on the horizon with more targeted therapies in which technology, including pharmaceuticals, could actually start to lower cost in the future rather than add cost?
Well, you'd hope so. We have some horrible chronic diseases that cost the system a lot of money. Type 2 diabetes and the consequences, kidney failure, hypertension, cardiovascular disease, and of course Alzheimer's disease are enormous cost drivers. And if we had magic bullets for those, and all I think we really need, for instance, in each condition is a way to delay their onset, say 5 to 10 years, as long as we don't unlock the secret of aging and keep people alive to 120. But assuming that we don't, which we might, but assuming that we don't, then we've got to ask, why can't we develop drugs like that? And as I look over the innovation ecosystem, what I see is public policy that encourages drugs for orphan indications. That's a good thing. There weren't any drugs there, but I don't mean to say this pejoratively. Those are generally not public health menaces, and they're not driving the kind of healthcare costs that diabetes and Alzheimer's are, though I'm happy we have those drugs, and I'm glad we have the Orphan Drug Act. I see in the ACA, the Affordable Care Act, 12-year exclusivity for biologics. And what that means is the companies move very quickly to develop proteins and antibodies that will be very expensive. A typical pill is a $200 a month pill. A typical infusion of a protein is $2,000 a month. So we're going to develop a lot of proteins. But what we're not going to develop is a pill that's going to delay the onset of Alzheimer's disease, or a pill that's going to delay the onset of type 2 diabetes. And those are the kind of innovations we need. So what we've got to do is we've got to ask, how do we align public policy and public good with what is the business model of Big Pharma? And right now, I think they're out of sync. And I think there are a lot of things, as we talked about earlier at the Ideas Festival, in the ecosystem that lead us to not take advantage of the biomedical revolution and the innovation that's possible.
Mm-hmm. So when we talk about chronicity and chronic disease, of course, we often retreat quickly to the medical model, right? How to treat it. And but we are beset with an epidemic of obesity, which according to the AMA now is a disease. And we don't seem to be having great success with our traditional model. We focus on the supply side of cost. How can we shift our emphasis to the demand side of the equation here, where we're really making headway into the behaviors and changing the behaviors of individuals so that we can address this epidemic of obesity? And it seems at some level that this is more an issue for behavioral economics. It's sort of, for instance, the Bloomberg soda tax, right? Is that the way we need to go? I mean, should we, instead of going to the medical doctor, should we be going to the doctor of behavioral economics to figure out how to tackle this issue? And Peter.
Sure. Well, look, a couple things. First, there actually is a smidgen of good news, at least on childhood obesity, which is childhood obesity rates over the past couple years have at least plateaued, and there's actually some evidence that they've declined slightly. So we're not where we need to be, and the rates are still much too high. But there's at least, I don't want to leave the perception of it's just kind of going off the charts. It's sort of like this, and we need to get it down further. First point. Second point, if you look at past successes, cigarette smoking being a good example where we still have a ways to go, but we've made a lot of progress in reducing cigarette smoking. It is typically a combination of price and social norm that changes. 20 or 30 years ago, if someone lit a cigarette in this auditorium, it not only would have been permissible, it probably wouldn't have been shunned upon. Today, forget even the law prohibiting that, it just is not kind of done, and that makes a big difference in terms of people's perception. And then price matters also. So now apply that to the obesity epidemic, and the answer is that we could be doing more to raise the prices of foods that are not good for you, because that will help. We could be doing more to use the insights of behavioral economics to not only dissuade people from eating unhealthy food, but also to encourage healthy eating and exercise. So for example, every major corporation out there, or the folks who are representing major corporations, there's very strong evidence that putting the good for you food at the beginning of the cafeteria line dramatically raises consumption of good food relative to putting the bad food at the beginning of the cafeteria line. And that's a choice that you all have to make in your corporate cafeterias. Every corporate cafeteria, frankly, should be putting the healthy food first. There's no reason not to, and it helps your workers. Similarly, on exercise, very simple things like signs suggesting that walking up the steps can help have been shown to improve people's, the probability that they actually walk up the steps. Lots of simple interventions. By the way, a friend of mine, Marilyn Moon, once pointed out that in terms of getting middle-aged men to eat fruits and vegetables, that the most effective thing that could be done is putting them on the same shelf as beer. So I'll just leave that one out there, but whatever it takes, I guess. The point is there is a developing field that studies what gets people to kind of alter things, and the key insight is you have to make it easy to do the right thing. That is the key insight from behavioral economics in terms of savings and in terms of exercise and in terms of eating right. You have to make it easier to do the thing that most people want to do. Most people want to be healthy. It's just small impediments or the easy reach for the bad food really makes it challenging for a lot of people.
All right, so suppose, I'm sorry, you want to say something?
Yeah, well, I could be a little more direct. I mean, I think that the data
And
shows,
Peter?
if we all weighed what we weighed in 1987 as a country, we would save $257 billion in healthcare costs. Let's multiply that times about 5, and you got the whole cost of
That's not
Obamacare.
just us, that's the whole country.
That's the whole country. That's the whole country. Right. These aren't big concerns.
You guys are doing great.
So what's changed between 1987 and today? And what's changed is the amount of sugar that's being consumed in our diet. And where does most of it occur? It's in our beverages. And our beverages have the quickest way to raise your glucose, and as a consequence, there's a very rapid fall, and you don't get satiety. You get all kinds of other issues that are surrounded by that. I think if we're going to get serious about healthcare costs, and we're going to get serious about the drivers of those costs, we have to start understanding the behaviors that are behind it, and I think we have to have some tough solutions. The easy solution, and this is the one that bothers me the most, is to just go after the hospitals and the large medical centers and to say, you guys are just so inefficient, I don't know what we're going to do. I mean, if I could find 35% more efficiency, I'd be a divine being. I mean, I just have no conception of how I could possibly do that. But I know that there are lots of things that happen in our hospital every day that are out of our control, like administrative costs and malpractice costs and the way people die and the way people come to us with obesity and the way they don't take their medications. I mean, all those things that drive enormous healthcare costs that are very hard discussions to have in the public forum. And I think those are the things we've got to start talking about.
I want to come back to the medical center issue, but Bob, go ahead.
I'll just say one thing. It strikes me there are two pieces to this, and I can remember back when I was in our administration, and as you may remember, there was a health care proposal. It didn't happen to happen, but it causes, whether for better or for worse, but there was a lot of folks. It seems to me there are two pieces of this conversation. One of them we have a lot of, and the other one we simply don't want to have. The one that we have a lot of is how to make the system work better, and that's obviously extremely important, and to try to save resources, to get best practices, to get most cost-effective use of our resources. But I still think that we cannot avoid what will be an ever-increasing problem or question, which is the question you start out with: can we afford our health care? And the question that takes you to, and I think it has many branches once you get into it, is how are we going to think about the full range of demand for health care, and then how are we going to think about how much of that we want to satisfy? And I think that whatever you wind up with is never going to be anything like the full demand that would exist if you met every single demand, and the question is, what are our criteria going to be? And those are just issues we do not want to discuss in our political system, and I think are incapable of discussing. I'll give you one practical event.
Yeah.
Should NIH be encouraged to fund all possible useful research, or should it be restricted to research that serve purposes? If NIH could come up with Ken's magic pill to extend everybody's life expectancy to 100, is that something we should allow NIH to do?
Well, this is the debate in the NIH. This is the debate that we see played out all across, fora that are interested in the funding of science. Should it be scientific merit, or should it have some influence, be somewhat influenced by the national priorities? Now, the way it currently is influenced by national priorities is that disease-focused lobbying groups get to their senators and congressmen and effectively make an argument that they should have a special allocation. And the scientists of the NIH, cower and say that's terrible, what they're doing to us, they're taking money away from other things. And the fact is that we have that tension between the purists and the lobbyists. But what I would hope we actually had was a directive from some other authority, perhaps in the administration, that sets out an agenda that says these things are more important. Alzheimer's disease, diabetes, chronic diseases, these are more important, and we will allocate dollars in a different way. And then we're also going to have scientific rationality, purity, and merit, but to some degree, we really do have to focus our research. The country can't afford not to focus its research.
Yeah, but that really was my point, Ken. No administration is going to issue an executive order saying we do not want any drugs developed that extend life beyond 90.
No.
But
so,
right. But
well, and not just for political expediency. I mean, the merit of that.
But I'm not saying that.
Well,
No, but
okay.
But now we're getting to the real debate.
Yes. Well, now we're getting to the debate. That's precise. By the way, I'm not advocating that. I don't want to be in the wrong place. I'm just raising it as a question.
So
let's say that it took 50% of GDP in our country to both extend everybody's life to 95 and also to pay for the increasing maladies that come with age. Would you advocate that?
Well, let's do a poll. Hold on a second. So if we could extend,
and remember, to take 50% of GDP, you have to have less education, less roads, fewer roads, less education, and less everything else. I think that's isn't that a fundamental question of your question?
Sure.
Yeah, but look, the fact of the matter is, we could afford to pay more than 18% of GDP, or even 20 or 25, if it were worth it. It comes back to, I think the real shame here is if we are spending money, whether because of administrative cost, malpractice, whatever, that is not actually improving health outcomes, that's just waste. And the numbers are so big that that's the problem. But if you were offered a straight up choice of paying even 5% of your income more in taxes in exchange for an extra 10 years of your life, I think who would take that?
Sure. But that was the issue.
Right, but the question is who would believe it, right? Because you have to pay the taxes up front, and then you only get the 10 years much later down the road.
Bob's saying, can we even afford it, and how can we finance it? And my point is, I think people would be that's exactly the point. People would be willing to pay for it, whether it's through taxes, out of their own pocket, reduced.
You need a written guarantee. You need some warranty, I think. Sort of money back sort of arrangement.
No, but you're I know Peter extremely well, so I kind of know how he operates intellectually. He has misframed my comment, my point. So,
but it was completely unintentional.
Why don't you try again?
Here, I'm going to do it again. You pick whatever hypothesis you want. All I'm saying is you increase life to such a great extent that it takes 50% of GDP. We can extend life expectancy to 120. I don't know. That was Ken's example. At some point, Peter,
We all agree we can't spend more than 100% of GDP on health.
There we go. So
Okay,
now,
so-
there, okay.
That's great.
So I think what Bob is looking
And
for
that starts to
is
drive
what-
us towards
at some level, I think
We
what Bob
agree.
is saying, what's the number, right? I mean,
How do you
at some
get there,
point,
and what are your moral considerations, what are your
right?
practical
And then what's the
considerations?
decision-making process?
Yeah.
And I
That's
guess
a good
my
I mean,
point
it's
is,
real. It's a governance process,
look,
right?
also a good
I guess my point is, I think we are spending too much on healthcare right now, but we are far away from. Bob's painting a different world where the majority of our output is devoted to healthcare. We are so far away from that point today that debating it, I don't think is the best use of our time. Instead, the debate should be how can we get more out of the 18% of GDP or the 20% of GDP that we're spending, because we could be doing a lot better out of that. And then, yes, at some point we're going to get to, oh my goodness, we're spending 50% of GDP. But by the way, it's also going to depend. If those 120-year-olds are still working, GDP is going to be higher. So I mean,
Oh, we will
the
be.
point
Oh,
is we're
but I
debating,
guarantee you,
the planet may have
we
blown
will
up
be
because we
working,
didn't address
yeah.
climate change. I mean, the point is there are lots of things out there 100 years from now. We've got a bunch of challenges over the next 10 to 15 to 20 years
so I wanna ask
that we
Ken
could really
then.
make progress on.
So Ken runs, I mean, he runs the premier medical center in the United States. And
That's because Peter and I are on the board.
Exactly right. Since they're my
yeah,
bosses,
it's an
I-
interesting relationship going
100%
on
true.
here. So anyway, I mean, can you find 30, 35% of, I mean, does this sound reasonable to you? I mean, what's the,
No, as
I mean,
both
let me
the-
just,
as both-
let me just set it up, right? I mean, academic medical centers, at some level, are the jewel of the American healthcare system, right? They're research, training, tertiary quaternary care. They would distinguish us from what goes on in the rest of the world in terms of the best of American medicine, right? It appears to me they're under assault. And in the current environment where you're really getting squeezed, how does an academic medical center survive? And does your margin allow you to find?
Could I just add to the question a little bit? Which is, but
It's long enough. I mean,
yeah,
no,
but in answering the
guy.
question, don't accept the external things as given.
As is,
So in other
true.
words, if you could reform malpractice, if you could reform the payment system, if everyone had an advanced directive, et cetera, then what's your number?
Well, no, that's not
Yeah,
the question.
yeah.
No, you reframed his question, then you reframed
that's
my
the
question.
right
I mean,
That's the right
we got to. See, I knew there was going to be trouble this morning when I talked to these guys.
So, how should
Answer both
I'm
questions.
going to answer both questions. To begin with, the leading academic medical centers in the country are generally older hospitals. They find themselves in more of the decaying areas of urban America. So they take care of a lot of underprivileged patients. At Mount Sinai, 17% of our patients are Medicaid, 45% are Medicare. So that's 62% of our revenues are coming from governments. Those governments are out of money. So they continue to decrease, to ramp down what those revenues are. But we live in a unionized environment, and we also live in an environment where technology marches forward and costs more money. So we need more 3T MRIs, we need more PET scanners with a CT scan, and the reason we need those is not because we do unnecessary tests. I mean, we really try not to do unnecessary tests, but we do them because we really think we're improving quality of life and saving lives from some very sick people who come to our hospital. So technology marches on, labor is inexorable in its expense, and the revenues keep shrinking. And if you're not living in a community that is middle class or upper middle class or affluent, the numbers don't start to work out. So what that means is these medical centers have to find ways to cross-subsidize services that they're performing. For example, if a Medicaid patient comes to Mount Sinai, we'll get paid about $100 for an emergency room visit. It will cost us $450. How do we pay for that? Every baby that is born at Mount Sinai, and we have some 17,000. We have a lot of deliveries in the Mount Sinai whole healthcare system that will, as it's growing. We lose $1,000 in every one of those because of malpractice. So we've got to cross-subsidize all those things, and at the end of the day, the margin is very, very narrow. What's the margin for? These are not for profits. The margin are for innovation. Why is innovation very important today? Because the biomedical revolution is giving us opportunities, but also because the big pharma business model has put them more in the development business than the discovery business. We're the fountain for new targets. We're the fountain for new molecules, for new therapeutics, for new diagnostics. If we can't afford to do that research anymore, the pipeline runs dry, and what we're going to get is more variants of Cialis and more sleeping pills and, you know, more commercials that you see all the time for all kinds of indications that, trust me, aren't life-threatening. So what
Might be a qualitative problem, but anyway.
So what we need to recognize is that we have to preserve what are these really bastions of science and, I think, iconic figures in medicine. Now, the other part, Peter's question. Yeah, we could make these places run a lot more efficiently if we just bite the bullet and look at some of the really bad policies that we have. You wouldn't believe this, but I'm going to tell you a number that you're probably going to find absolutely phenomenal. At Mount Sinai, we deal with about 350 different insurance policies. You think there aren't that many insurance companies, and there aren't. But they've all got different policies and different nuances, and each one is a different claim form and a different billing form and a different billing procedure, and that produces an enormous overhead. The ACA has administrative simplification. We're still waiting for the regulations. We don't know what it's going to mean. Will it be electronic billing? Will it be electronic transactions? Are we going to have a single payer claim form like we have for Medicare? It could save a lot of money. Peter has proposed, and others have thought about, some safe harbors around malpractice so that we could, you know, really, I think, make rational this system here. But without it, there's an extra cost around malpractice that we have to deal with. So those are behaviors that are out of our control. Also behaviors that are out of our control are the patients who come at the end of life and want a miracle. And they're sitting there intubated with 4 IVs, some of them with a ventricular assist device, and the family's begging for more. I mean, that's killing you guys. That's costing a fortune of money. I mean, 30% of the Medicaid dollars go to 5% of patients at the end of life, in the last year of life. A bunch of those people are in nursing homes, and the nursing home gives up in the last week or so, send them to the hospital, triples the cost. And 95% of those people who are sent to the nursing homes will die within 30 days. I'm saying they're sent to the hospital, will die within 30 days. We got to address these issues. So if we could do those things, yes, we'd have a much better margin. We could continue to innovate. But what I despair over is that the public debate is about the charge master. I mean, that has nothing to do with what's going on today, really.
You raised a really good question. You start out by saying, can we afford our health care? I think you could also have asked another question, which you actually did raise. Do we have political processes that are capable of dealing with the complexities of our healthcare system, of which the complexities are vast, obviously? And I think the answer is clearly not.
I mean, the public debate is, I mean, it's a complex issue, and it's reduced to a cartoon conversation.
Exactly right.
And nobody wants to face difficult issues, and they don't understand. If you go, with all due respect to our Congress,
Yep.
which now has a 10% approval rating on MedEd, you'll have a very difficult time finding any elected officials who actually understand the complexities involved.
So we're coming up to the point where we're going to switch over to the audience. I just want to get a couple of quick questions in. So, Peter, there seems to be a very aggressive wave of hospital consolidation going on across the country right now. What's driving, and to the point where people are saying, you know, in 10 years there's going to be 3, 4, 5, 10, maybe large systems in the country. What's driving this consolidation, and is this really, these sort of local monopolies really put at risk any attempts to drive costs down?
Well, I think a big reason that we've seen an acceleration or the desire for a lot of hospitals to merge is that the payment system, as I mentioned at the beginning, is changing. A hospital system that gets a bundled payment or an accountable care organization, an ACO payment. So instead of getting, I'm going to pay you each time you do something, you get $8,000 to take care of me for the entire year for everything I need. Completely different situation and completely flipped incentives. At that point, the distinction between a hospital and an insurance company is actually really kind of hard to detect, because the hospital is at risk for intensity, for how much care a patient needs, and is effectively acting as an insurance company. So if you think about it from that perspective, a lot of hospital systems don't have sufficient scale to be an efficient insurer. They don't have minimum efficient scale from an insurance perspective to be a low-cost insurance provider. And so there's a desire to expand horizontally. There's also a desire to expand out into auxiliary services, because again, if I'm financially responsible for that outpatient image, that I want to actually make sure that I have some sense over or some control over, what exactly is happening in independent facilities or formerly independent facilities. Now, all of that's fine from the perspective of trying to, create a different payment system. But where it's not fine is from an antitrust perspective, because what we've seen over the past 3 decades, returning to hospitals, is increasing concentrations in local hospital markets, increasing market power from previous mergers. And that trend over the past few years is accelerating. So right now, and I see this actually in my day job, there is a collision course between the health policy pressure for hospital systems to basically get bigger to handle the risks that they're being asked to take on, and the competition policy imperative of maintaining local competition in lots of different markets. And those are bumping up against each other in quite dramatic ways, sometimes stopping deals from happening, sometimes not, and people wondering, well, why did that deal go through and this one didn't? And I actually think this is a major area that requires some policy clarity, because the two imperatives are in conflict with one another, and some policy process needs to say, here are the ground rules for when we're going to allow mergers and when we're not.
Great, thank you. So why don't we go to the audience and get some hands up there. We have a microphone coming around, and this gentleman here was quick on the draw with the black shirt on there.
Thank you. In this conversation, I haven't heard much about signals to consumers on price. I'm a guy who's lucky and has a great insurance plan and everything, but I always have felt this personal responsibility to be responsible for trying to keep my share of costs down. So I went and asked, got a knee that didn't hurt. It hurt, and I went to the doctor, and he said immediately, well, go get an MRI. So I went to the person. I said to the person, that they said, go schedule it there. And I said to the woman scheduling, how much does this cost? And she said, oh, your insurance covers. You got a great insurance. No, how much does this cost? She had no earthly idea. And I've never seen a place where if you actually ask people, what does this cost? There's very few people who seem to know. So could y'all talk a little bit about that side of the question?
Yeah, I think it's a great question. Nothing illustrates it better than the cover story in New York Times today, where you couldn't even get a price for pregnancy and delivery, which you think is a fairly standardized thing in most cases. So I don't know, Ken, do you want to tackle that? And
Huey Reinhardt writes very well about this question. It's the legacy of World War II, and the price controls there led to other ways to incentivize workers, and it was through benefits, and that's how we developed an employer-based healthcare insurance system. So the employers were paying for it, and as it became increasingly expensive, the employees would kick in some percentage of it. And the successful unions, like in our case, the healthcare unions, put in very, very little, if anything, and the employer pays everything. But the beneficiary of the policy has no idea what's going on, and they don't care. There is no market. So they walk in, and it just is what it is. And what happens is, in that opacity, what goes on is that the insurance companies then negotiate individual contracts with the hospitals or with large physician groups, and everyone's different. Everyone's unique. And what they then post in their charge master will have absolutely no relationship to what the deal is that they made with Aetna, or what they're getting from Medicare, or what Medicaid's paying them. So, we got this legacy system of opacity. But what's happening in recent years is that copays are going up, deductibles are going up, defined benefit is coming in, a maximum allowable that that the benefit is going to be is being capped. So consumers are starting to pay more. What we've learned at Mount Sinai, our mantra is copay is no pay, because we get such a poor percentage of patients who, when they find out what their copay is, wind up not paying. And, as a not-for-profit, we're not in the business of getting people on trying to go after those bills in an aggressive manner. So I think it's changing. We're getting some increased transparency, but until the system fundamentally changes, And I don't see that happening until we move away from the fee-for-service model and to a value-based model and a population risk model. We're going to be stuck with these incongruities. But what I'd like to finish this point in is the following. The Brill article is not going to be some great muckraking piece of information that will revolutionize healthcare delivery. He found the charge master, it varies, and that some CEOs make a lot of money. You know, that's not going to change the healthcare system. It's really not. These issues that we're talking about today are going to change the healthcare system.
So I'd say two things. One is good news, bad news. Good news, Ken already mentioned, which is that the situation is changing, not only because employers are moving towards basically a defined contribution model for their employees, which, by the way, I think will become increasingly dominant over the next decade, but also because price transparency is slowly improving, places like Castlight and so on and so forth. So the trend's in the right direction, but from a low base. Now here's the bad news. I don't think it's going to matter quite as much as most people think. So it's helpful, but not as helpful as most people think. And here's the reason. Healthcare costs are extremely concentrated. The top 25% of Medicare beneficiaries account for 85% of total spend, okay? And those are the complex, costly cases. So that's fact one. Fact two is any insurance plan, even the defined contribution, consumer-driven approach, is going to provide deep third-party insurance against catastrophic costs because, by the way, that's the whole purpose of insurance. So you put those two facts together, and you don't get as much traction from cost sharing and transparency as you might think because most of the costs are in those high-cost cases, and you're always going to have a pretty low-cost copayment against those costs. So that brings me back to, well, what is driving those costs? And part of it's behavioral. But once someone's in the health system, those costs are driven to a first approximation by what the provider's recommending. To a first approximation in the really complex cases, what the provider says should be done is usually what happens. Not always, but usually what happens. And that brings us back to, if you accept that proposition, you better be affecting what the provider's recommending or you're not making much progress. And that in turn brings you back to what are the providers, what's his or her information flow like? And are you using clinical decision support software to affect it, and et cetera? And what are their financial incentives? Including malpractice, by the way.
All right, gentlemen over there. I see a fair number of hands. Why don't we treat this as a lightning round? Let's see if we can get them 60-second answers and get as many in as we can.
I really appreciate the panel's talk about the end-of-life issues. I'm a practicing physician myself. I'll just mention 3 or 4 things. One is, if you look at sacred cows like smoking, for example, the cost of people who smoke, healthcare-wise, is 60,000 euros less from age 20 on than people who don't smoke, related to the end-of-life issues. Another one, the cost of women in medicine. We all want women to go in medicine. My daughter, I hope she goes into medicine. But 40% of women in medicine are part-time employees from age 35 to 50. The other one is the electronic medical record, 30% decrease in productivity. So I'm very interested in Secretary Rubin's comment that we don't have a format to address this end-of-life issue, which is the big issue. And we come up with all these other things that we don't really figure out the cost of, many which theoretically sound great, but are extremely costly.
So I don't know if that was a question.
Well, let me
or an
talk about,
observation.
in New York State, we have mandated that, well, the state has, that every hospital over 150 beds has to have a palliative care team. Palliative care has been shown in study after study to prolong life, not shorten it, to improve satisfaction by both family and the patient for those time that's remaining. Yet, it's not something that we want to talk about on a broader scale. We can save a lot of money with palliative care, and we can provide more humane treatment.
The question was, what does it take to address that issue formally, not under...
Well, it takes a Congress that doesn't want to scream death panels.
It takes a...
It's part of what Bob was saying before, Bob. I don't know if you want to sort of articulate this.
No,
this
I'm sorry. It takes a political system that is willing to face issues, that understands issues, and that's willing to make tough decisions, none of which we have.
Back in the corner there, red hat.
Dr. Davis, can you talk about the training of new doctors and what you're doing from an educational standpoint and the new generation of doctors that'll come in and be part of the cure, hopefully?
Well, care is changing enormously. We look for different students now, and we train them differently. It would be a long discussion on what we do, but let me just say that we think that students from broader backgrounds can become doctors, so we like mathematicians as well as we like humanists. We don't necessarily think we learn very much from the MCAT exam. We think we have to train doctors to be team leaders, to be part of teams, to not be the genius who walks on the ward and figures out what nobody else could figure out, but is the leader who can organize and mobilize a group of healthcare people of different licenses so that they can maximize the quality of care over the spectrum of a patient's disease.
Right here, front, and then I'll come to the side, which I've neglected, I realize.
Hi, I'm just wondering who in this audience would be willing to forego tests, routine preventive medical tests in order to save costs as a matter of national policy?
Can I talk about this? This is a critical
Which
question.
test?
Any test. Let me raise it. Let me speak to this for a second because it's very important.
I mean, I'm someone whose cancer was detected not symptomatic, just through a routine mammogram, even though it was not recommended that I have such
Right.
testing.
Right. We talk about this as if it's always the providers who are saying, you got to get that test. You forget how many men and women, when they heard about the restrictions that the new guidelines on mammography and PSA said, what, are you kidding? I want to know. But that gets me to another point, which I think is really, really critical. When I was in medical school, which is a long time ago, the doctor who we would all admire was the doctor who made the rare diagnosis that nobody else could figure out. And that doctor made the rare diagnosis because he often ordered the test that nobody else could have thought about. And as a consequence, as I was a house staff officer, my senior house staff officer talked about a spinal tap and said, if you just think it, do it, which was the mantra and kind of the culture. We're here to save lives. And if we save one life, it's worth it no matter what the cost. Now that is totally turned upside down. Now, if we do 99 tests to save that 100th patient, we're told that that's profligate, and that there's something that's grossly inefficient, and how dare we do that? And you know what? We're teaching our medical students now that it is profligate. But the question comes down to, what is a human life worth? And that's what is absent from this debate.
You just made the point far better than I made it about this whole question of how we're going to deal with the issue of access. That's your point. And if somebody comes to me and says, there's a 1 in 100 chance that something might be wrong, and we'll give you the test, on a social and on a broad social basis, it probably shouldn't be done, but I'll tell you, if it's me, I want it done, which is your point precisely, and it goes exactly the questions I was trying to raise before, and nobody in our society wants to face.
But I think
Good
it's
thing you weren't at the Zeke Emanuel panel.
right. Well, no, but that's where I was actually going to go, which is this is an extremely hard question. But rather than framing it in terms of what tests you would forego yourself, you could also ask, how many of you would be willing to have your taxes be $1,000 a year higher for a whole bunch of tests that lots of people get, that the medical evidence suggests that even on an individualized basis, that for them, it doesn't make sense to do. And that's fine. You would support it. The problem is most of the population would say, I don't want to support those tests for other people. So therein lies the challenge, which is, and it might lead to a perspective, by the way, which I think you could do of, it's consistent with the value-based insurance design, where basically if the test for as disaggregated a slice of the population as possible seems to make sense for you, fine. If it doesn't, you can still, of course, do it, but your copayment is going to be a bit higher. And that way, people who want to get the test can do it. Now, it fortunately brings in a little bit of the resource question, but we're going to be, as a society, facing that anyway. And so you don't avoid it by just propagating the system we have where we're paying for pretty much anything. But I think that the right approach is what I just mentioned, which is to go as disaggregated as possible. And if you still want to do it, even though the evidence suggests that as disaggregated as possible, it doesn't seem to be indicated, you're going to have to pay more for it. So that we just make
Bob
sure.
is starting to twitch over there.
Yeah,
No,
that's
I'm just
fine.
saying that's access by affordability. You also better be careful about what you wish for. Peter said before that now we're going to have financial incentives instead of different set of incentives, right? In bundling and capitation. Yeah, that's what you said.
Well, we already have financial incentives. The
I
question
know,
is,
I know.
what are they?
It's a different set. No, it's a different.
Bob, we've actually recorded it, so we can go back and see
Right,
exactly
yeah.
what he said.
It's a different set of incentives. Now it is to be more efficient, to provide the value.
Right.
Okay. But there may also be incentives that you don't like, which is in a capitation bundling system. Maybe the incentive is not to provide the best possible care, but rather to provide the least care that you can relative to the dollars you're going to get. And the question is, how do you deal with that? Which is also not a very simple issue, I think. The larger point simply, this thing is massively complex, and we have none of the processes necessary, in my opinion, to make sound judgments for our society.
Now, Andrea's question relates to tests that she knows about, you know, mammography, PSAs. But for every one of those tests she knows about that Peter says you could ask for that test and then you could pay more, there are lots more tests you don't know about that your doctor knows about. But when your doctor is in a healthcare system, as we're moving toward, and I fully support, we're an accountable care organization, we're prepared to manage risk, we understand that fee-for-service is dead. I believe over the long term. The country can't afford it. But there will be, as a consequence, tests that the doctor will not do because the doctor knows the chance is only 1 in 100 and he can't support it. And in fact, what happens at the end of the year now is doctors are given a profile of what their resource utilization is. And if their resource utilization is outside the norm of what for that practice or for patients with that diagnostic group, that doctor's not going to get the same bonus as a doctor who is more resource efficient in what they do.
But here's the problem, though, Kent. What if it's better than the norm?
What do you mean better?
Well, you said if the resource
Oh
utilization...
yeah, he's going to get a bigger bonus if he's better than norm.
Therefore, it seems to be my incentive is to give as little patient, as little care
But
as
the
possible.
good news is, and thanks to Peter and his team, when we drew up the ACA and we talked about the ACO, there are quality metrics that you got to meet. And the difference between HMOs in the past and what we're moving toward, hopefully, is that we'll have some rigorous quality measures, you know, around how you manage diabetes, how you manage hypertension, how you manage congestive heart failure, you know. But I think that's good, and that's going to help a great deal.
I think you've now, by the way, illustrated why this is not the auto sector. I mean, people, obviously there's a lot of emotion because it affects people's lives.
Right,
I mean,
and the other question is, right, I mean, in your case, if it wasn't covered, you could afford to pay for it. You could say, I want that test, whatever. There's this whole disparity issue around folks who don't have that option. But let me come to this side of the room here. In the back.
Oh, thank you so much. So as I listened to this discussion, I heard a lot of ideas that you've been talking about, realigning incentives, medical malpractice, more disclosure, more competition. From each of you, in terms of cost containment, can I get the top 3 things you would like to see or changes, very quickly, that are non-draconian?
that are what?
Non-draconian.
Non-draconian.
Yeah.
I'd say, for me, it would be advanced directives that would be so incentivized that we would know what everybody wants at the end of their life. It would be administrative simplification, which I think is just a killer. And I think it would be a realignment of the incentives of exclusivity in patent law so that we could encourage a greater alignment between big pharma and discovery in the academic medical centers.
I would say that I would want a share certain, so let's just say 90% of total healthcare revenue by a date certain, 2020, to be non-fee-for-service, so either bundled or accountable care organization type, 1. 2, I would support the idea of, I mean, I'll just, you know, I'm not in office, so I can be a little bit more direct. I think it should be mandatory that you have an advance directive if you are admitted to a hospital. And again, the advance directive doesn't dictate anything other than you indicate what you want to have happen to you. It is the ultimate consumer-driven healthcare.
Right.
And yet it's actually rejected the most vociferously by those who typically favor consumer-driven healthcare. And then the final thing is, Ken mentioned this before, and I part company from the academic literature in terms of its importance. I would reform the medical malpractice system so that if my doctor is following what a medical society, professional medical society has put forward as best practices protocol for as disaggregated my situation as disaggregated as possible, I should not be able to sue my doctor. Simple as that.
Bob?
Yeah, I don't think I'd add too much other than to say malpractice insurance, which Peter mentioned last. The advanced directive, which Peter said is what consumers want. If consumers want it, then it doesn't have to be mandatory.
No. I'm saying you have to tell us what you want. You have to
Okay.
require them to say, I want blue or red.
Okay.
Or say we don't want it. Or
And
say
I
we
guess
don't want it.
I guess the other thing, I'd like a solution to this question of how are we going to make more rational decisions about health care. And then another question which you raised this morning we haven't discussed just now is how are we going to provide effective management for these mega institutions that we're creating?
We didn't have time for that. I was going to ask that, but they're on deck now. So let's go to.
There's something I don't understand, and I'm not a doctor, I'm an economist. In every other industry, innovation leads to costs coming down. Somehow in healthcare, that doesn't seem to happen. I don't quite understand. And so, could you perhaps shed some light on this? And if you think that's true, could that perhaps, if we indeed would get a return on investment on the project of the human genome, all of these things, and that's just one example, if we could get a return on the productivity improvements that are being made, digitization, etc., could then the cost curve that so worries us for the budget actually not be like this, but like this? And we talked about this a little bit yesterday. I know this is not the only
running out,
factor,
yeah.
but
The question
this
is,
particular
Why
one
does it
just
innovation
puzzles me.
costs instead of reduce
All right.
it?
And I think from our point of view, it's because at the, as I said yesterday, we all have an expiration date. And the last year of life is very expensive. So what a lot of innovation does is it treats some of the conditions that you're having, but it doesn't give you immortality. And at the end of the day, you're still going to have some bad diseases that are going to get very expensive. However, think about the polio vaccine. I mean, obviously that saved a lot of money to the healthcare system. And in my father's generation, for benign prostatic hypertrophy, everybody was having their prostate reamed out. Now, drugs like Urexatrol keep you from doing that for years. So there are drugs that really do decrease costs, but we should also remember that, a lot of these diseases we just delay.
30 seconds.
Really brief incentives. I mean, right now we have an incentive for new technology. As long as it improves even a smidgen on existing technology, we will pay whatever it costs to introduce it. In the auto industry, if a car was had a 1 mile an hour efficiency improvement in terms of whatever fuel efficiency, and it cost $100,000 more than the existing car, everyone would say that's ridiculous. Of course, we're not going to pay for it. But in healthcare, we'd say that looks great. Let's get the new car.
So we're down. So we're just about out of time. So let me just pose one last lightning round to the group here. Just 30 seconds each. Back in the 1990s, healthcare curve flattened. People were very optimistic about it. And it took off again. Now it appears to be flattening again. Peter's optimistic that there's some real structural things going on. There's going to be. Let's think. 15, 20 years from now. Are we going to be, is this thing whole going to be worked out and settled? Are we going to be on the right path? And, and the structural changes now that Peter, you've helped introduce are going to, the road to the future is going to be solved? Or are we going to be back here saying, we got to straighten out this healthcare thing, and what is it that we're going to have to do? And we'll start with Bob.
I think that with given demographics, it's 30 seconds, right?
30 seconds.
No, given demographics, given the potential that technology will have sooner or later, genomics or however it happens, to continue to extend life and to deal with all kinds of maladies that we now have in more effective ways, I think we're heading toward a terrible collision. And our political system is ultimately going to have to face the question it doesn't want to face, which is who's going to get care and how is that going to be determined. So I think somewhere, I don't know if it's 15 or 20 years or it's 5 years or it's 20 years, but even if Peter's right in everything he says, sooner or later there's going to be a collision out there, I think it almost surely has to be the case.
Peter.
I agree with that. I just don't think it's going to come within the next 10 years. I think actually I'm pretty optimistic that for the next 5 to 10 years, there's going to be a lot of progress made in changing the payment system, in digitization, et cetera, that will help to mitigate this. And unlike in the 1990s, the backlash from that is likely, I mean, there will be some backlash, but it will be less severe because we're putting Ken in charge of, is the front. The provider's the one kind of on point instead of the insurance companies. And it's a lot different if your doctor says, I don't really think you need that, as opposed to the insurance company saying, we're not going to pay for that.
Right. Well, I agree with what we've just said. I think the accountable care organizations, value-based purchasing, population management for the next few years will increasingly come into play, and it will have a beneficial effect on the population. But what I see long-term is what Bob sees. I see that the country neither has the will nor the dollars to afford the health care that they're going to need, and we will get a multi-tiered system. The affluent will pay out of pocket for the care that they need with some subsidy from the government. Then there'll be a middle tier of employed people in middle ages who are going to have to also pay more out of pocket, and the poor will have the lowest level care and will have the poorest insurance.
Well, I think, thank you,
Don't
gentlemen.
applaud on that.
No, I mean, thank you for a wonderful panel. Appreciate it. Thank you to the audience. Great audience.